Dr. Ajay Kumar ji. Good evening, everyone. My teachers, seniors, and honorable office bearers, our respected chairperson, sir, Rawat sir, and dearest Dr. Minu Singh ma'am, Dr. Indu Khosla ma'am, and to be joining Matthew sir also in absentia. So I welcome you all on board for this inaugural session of start of a journal club presentation series, which was actually conceived by our chairperson, sir. So on discussion, he proposed this idea, and he wanted any new study and drug or anything, any research, which would go a long way in redefining our approach to management of pediatric pulmonology cases, which would be very, very useful to our DM pediatric pulmonology fellows or even MD residents. So it will be every month on third Wednesday from 9 p.m. to 10 p.m. and today is the inaugural session. So I welcome you all for this inaugural session. Thank you so much.
Thank you, sir. Now I invite Madam Indu Khosla, ma'am, our national coordinator, to express her views. Ma'am, please. Indu Khosla, ma'am.
Yeah, I'm here.
Yeah, ma'am.
Rawat, you're on mute.
Pranab, please unmute and give your views regarding the session and then the aims and objectives. She didn't hear it.
Sorry.
Please.
Ma'am, unmute yourself, ma'am.
Yeah, sure.
Yes.
Good evening, everyone. It's my pleasure to be on this platform today, where we are looking at reviewing what is happening new and exciting in the field of pediatric pulmonology. More importantly, what we are all looking forward is to teach and to learn how to assess or review an article in the true light. In this today's world where we have so many publications, an attempt to be made to understand which is a correct article written in the correct form, which can be a format for future guidelines, is the most important thing to do. Our fellows who are going to be trained under us, I think they definitely need to understand this in the correct perspective. And I definitely thank Dr. Rawat for taking this initiative from the IAPNRC to start this program. I definitely thank all the other office bearers who have worked hard to see this program the light of day. Without doing much ado, I think we should just go ahead and start with this, the first IAPNRC General Club, and I'm sure all of us will benefit with this. Thank you so much.
Thank you, ma'am, for your views and your kind words. Now I invite our respected chairperson, sir, Rawat sir, for few words, sir, regarding this opening of new milestone in our this IAPNRC chapter, sir. Please, sir.
Thank you, Dr. Ajay Kumar. Respected office bearers of IAPNRC, respected Minu Singh ma'am, Dr. Indu Khosla madam, the national convener for this course, Dr. Ajay Kumar, all my dear EB members who are on this platform, and all the dear delegates, fellows, and faculties who are there on this platform. I bring warm greetings from IAPNRC. I'm really honored and privileged to present you this new academic initiative of IAPNRC, the IAPNRC Journal Club. As you all are aware that we started fellowship in pediatric pulmonology about 2 years back. Presently, about 8 centers are conducting this fellowship program, and one batch has already graduated from these centers. Feedback from these fellows was very exciting and very comfort to us. But with one lacune, everybody told in one word that they didn't get much opportunity to interact and discuss various articles in the journal. I feel the capability to understand, imbibe, extract relevant information from articles in the journal is a core competency which must be there in all pediatric residents. And this forms a strong foundation for the future research. Moreover, even in practicing pediatrician, this is a very well required skill because this will help them to imbibe important information which is relevant to their clinical practice. So I think this is a very important activity, and IAPNRC sends the need for this particular program and it incorporated into the IAPNRC Presidential Action Program for 25. I am thankful to Dr. Ajay Kumar, who is pediatric pulmonologist at Delhi in Safdarjung Hospital. He is also our EB member from North Zone. He has accepted to be the national convener for this course. I am thankful to Dr. Indu Khosla, who is pediatric pulmonologist at SRCC Mumbai, to coordinate the session, and she'll be the expert in the she'll be moderating the session. I am really thankful to her for her acceptance and to be the part of this program. The jewel in the crown is presence of Dr. Joseph Matthew. I'm feeling words to describe his expertise in research and evidence-based methodology. He is an expert guide, and we really look forward to his guidance in understanding various articles and the way forward how to conduct this session. I'm sure that all the delegates who will present on this day, they will be fortunate to hear his advice and hear his guidance how to go ahead with understanding various articles. I'm really thankful to our president, Dr. Vasant Kalatkar, who has agreed to be here on this platform and bless us. And I'm surely his motivating words would help us to be more innovative and work more harder to get more and more better programs for the chapter members. So friends, I invite all of you to attend this session, imbibe the important information which is there in store for you in future months. Mark your calendar, third Wednesday of every month at 9 o'clock, and please bless us by your presence. Thank you very much. I again wish you a very happy learning. Thank you very much. Back to Dr. Ajay Kumar.
Thank you, sir. And this is only for due to happening due to your vision, sir, your visionary approach. And I hopeful that under your leadership, the IAPNRC will go to the next height. So I thank you again, sir. And I invite our president, IAP, Dr. Vasant Kharetkar, sir, for his few words regarding this inaugural ceremony. And I welcome, sir, for this inaugural ceremony, sir.
Yeah. Good evening, all. Really, I'm first want to say sorry for joining late because of few appointments and everything is going on. One session was also one administrative meeting was going on. Respected chairman, secretary, all the executive board member and my colleagues. I welcome you all from the Central IIP side. Greetings from the IIP. And this is the really one of the vibrant chapter amongst all 3-4 chapters doing well. And now you got the really vibrant and visionary chairperson. You got with vibrant secretary, dynamic secretary. So this I know this year this chapter is going to do best. I'm fortunate that chapters conference, national conference is in my city this year. Our Dr. Shilpa, Dr. Vinod, all are geared up for this conference. And this concept journal, this is really good concept because in our old days we have to search all the journal in our library and then present it to, but it was very difficult. Nowadays it's because of a digital media and digital age. Now it's a, though it becomes going on. I know nobody is taking care of all this unless until there is some thesis or some need is there. But Dr. Sanjeev, innovative personality. I know always he always search what to give new to our members. Initiative not to, will be useful not only those who are a member of respiratory chapter, but all over in our member, that 47,000 member, where I'm very good strength. And I request next time you send this link to me, I will make it viral to my broadcast group, or like something through mail or something. I am promising you. I really wish you all the best. Wish you happy learning and happy new year to you. Jai Hind, Jai Happy. Thank you.
Thank you, sir.
Thank you, sir, and for your support in the future also, sir. We need, sir, your support in the future. And now I invite Dr. Sanjay Bafna, sir, for the vote of thanks, sir.
Thank you, Dr. Ajay. Good evening to all. It is a great pleasure for me to deliver this vote of thanks for the inaugural session of Journal Club of IAPNRC. So after the successful running of monthly case presentation for last 2 years, this is another important, unique educational activity which has been planned for fellows and fellow pediatric pulmonologists under the visionary leadership of Dr. Sanjeev Singh Rawat. IAPNRC is really greatly indebted and very happy for his presence. We are really thankful to Honorary IAP President Dr. Vasant Khadatkar for gracing this occasion, and I'm sure he will continue to support IAPNRC activities during his tenure. I thank my friend Dr. Indu, who has accepted to be a national coordinator for this session, and Dr. Ajay, who is a session convener. The article will be presented by Dr. Khushbu from AIMS, Rishikesh, and who is mentored by none other than Dr. Meenu Singh, who all of us know has done phenomenal work in the field of research in pediatric pulmonology. Thank you very much, madam, for being here. And I also welcome and thank Dr. Joseph, who is our go-to man actually for IAPNRC for anything related to research, be it guidelines, journal, or any other research activities. Thank you very much, sir, for this sparing your time. And I'm sure this activity will go a long way in keeping all of us updated and also stimulate the fellows and resident doctors to do some research in their respective field. Thank you very much. And I think without much ado, I hand over the mic to Dr. Ajay Kumar to start the session. Thank you so much.
Thank you, sir. Now I invite Dr. Indu Khosla, ma'am, National Coordinator, for starting this session, ma'am, please.
We have a very prominent person, Dr. Meenu Singh, who has mentored a student, Dr. Khushbu, for doing the inaugural program of this journal club. And I think this is one of the we are all privileged to have a senior teacher like Dr. Meenu Singh and her student do this. So the aim, this I want to talk for students who are going to be presenting the journal, the journal club presentation. So they have to choose an article where they have to analyze the article in depth. They have to tell us about what was the form of the study, whether it was a different. We know there are different kinds of studies, and we will have Dr. Matthews enlighten us post the session on the kind of study that Dr. Khushbu is going to present. So they have to analyze the whole study in depth, whether the study was appropriately done. We all know about the PICO question. So they have to start by analyzing the study by using the PICO question. And they have to also look at what could have been done better or what were the limitations of the study. And in brief, they have to also tell us about the statistical analysis which is used to do the study, and they should throw some light on it. So this is how a wholesome approach has to be done for the study. So before much ado, I invite Dr. Khushbu to start her presentation, and she is going to talk on use of prophylaxis for MDR-TB, the article which is from the NEJM. Over to you, Dr. Khushbu. Please share your screen.
Good evening, ma'am. Is my screen visible, ma'am?
Yes, can you make it in the slide format?
Yes, ma'am. Just
Yes.
good evening, esteemed faculty and all the members and chair bearers of IAPNRC. Good evening, Neenu ma'am. Good evening, Indu ma'am. And good evening, Joseph sir, the mentors and the coordinators for this session. Shall I begin, ma'am?
Yes, please go ahead.
So the article we shall be discussing today is titled Levofloxacin Preventive Treatment in Children Exposed to MDR Tuberculosis in TB CHAM Trial. So this was an article which was published in NEGM in December 2024. So in the background, the Global TB Report of 2022 has told that India has reported an incidence of around 316 per 1 lakh populations. And we have a prevalence of around 5.1% in children of MDR TB. We know that in new cases, the prevalence is found to be 2.8%, while in previously treated cases, it is 14%. However, there is a good news that the treatment success rate for MDR TB of all enrolled patients is on the steadily rising end. Worldwide, it is 68%, and India, it is found to be 65% as per the India TB report 2024. The efficacy ranges anywhere from TPT, which is the pillar of NTB strategy for India in 2025, ranges from 60 to 90%. So this is from the global TB report, where we see that we have decreased from our incidence in 2010 to 23 by 8.3%, but we still are lagging behind the target of 2025 of 50%. And we see that MDR TB incidence, people who are living with it, have been fairly stagnant, although in the decreasing trend. So treatment success rate for MDR TB is gradually improving. And we see that this should be good news if we are able to implement treatment. But one more thing is that we need to prevent new cases. So when we come to TPT coverage, we see that we are still at a 21% rate, where the target for 2027 for an NTB WHO strategy of 2035 is 90%. So we are nowhere near. As per the guidelines, levofloxacin has been recommended for 6 months for treatment for prophylaxis. Detailed dosing regimens have been given. Although this drug is not FDA approved, it is being used and being endorsed by WHO as well as all guideline bodies for prophylaxis as well as treatment of MDR TB. So coming to the article, this is an original article, TB CHAM trial, that is tuberculosis child multi-drug resistant preventive therapy trial. The lead author is AC Hesley, and it was published in NEGM in December, and it was sponsored by the Stellenbosch University in South Africa, as well as the University College of London. And we will be now proceeding to appraise this article using the CONSORT guidelines as well as the CASP, that is the Critical Appraisal Skills Program checklist for RCTs. So this is a community-based, multi-site, double-blinded, randomized trial, which is placebo-controlled. It was conducted in South Africa between 2017 to 2023. Coming to the PICO format of this, we see that the population here is contacts of bacteriologically confirmed MDR TB adults who are living in the same household. So these children who are the contacts of these MDR TB confirmed adults who are living in the same household for at least 6 months. So all contacts less than 5 years were included. However, for 5 to 17 years of age, they had to have an IGRA positive or an HIV positive test. Intervention was levofloxacin given for 6 months as OD dose for these contacts as TPT, compared with the control, which was placebo, given for the same duration. And the primary outcome, which was detailed as the incident tuberculosis, which was either microbiologically diagnosed or clinically diagnosed by 48 weeks. They've also given a leeway period of 6 weeks for follow-up. And then the secondary outcomes were mainly related to the adverse effects. This was the primary safety outcome, an adverse effect of more than grade 3. The incidence of TB to an extended period of 72 weeks. Other outcomes related to adverse effects, treatment adherence, as well as discontinuation of treatment. So in this incident tuberculosis, they also mentioned death by due to tuberculosis as an outcome. So coming to the abstract, we see that the abstract is well structured in the journal. It has a background, it has methods, results have been clearly mentioned, as well as conclusion, and they've mentioned the supporting strategies, and the registry number for the trial has also been given. So we'll be simultaneously seeing the CONSORT statement if the article is justifying it or not. So the only thing that we didn't find was that the title did not mention that this is a randomized control trial in words, although the abstract was well structured. Coming to the introduction, they've given a scientific background that among children who are less than 5 years of age who have been exposed to tuberculosis, within 1 year of exposure, around 80% of them develop tuberculosis, and observational data from before. So before this trial, there were no head-on trials. Recently, there have been 2 trials, the weak wind trial as well as the TB sham trial. Before this, there were only observational studies and systematic reviews based on these studies that had suggested that fluoroquinolone had some protective effect and would reduce the risk of tuberculosis developing in the contacts. So there have been modeling studies which have said that the 2 main pillars of NTB strategy should be either finding the cases and treating them or giving TPT to the contacts. Both, when go hand in hand, would be the ones which would help us. Hence, this study was conducted with the specific aim and objective of seeing the efficacy and safety of levofloxacin as compared to placebo as a TPT in children and adolescents with household exposure to an adult with infectious MDR-TB. This was microbiologically diagnosed. So we see that they've mentioned a clear scientific background in the article, as well as they've given specific aim, objective, as well as a hypothesis. Coming to the methodology of the study. So this was a multi-centric study. There were 5 sites in Africa, as have been detailed in different studies, thus representing a widely based population. It was a community-based trial, multi-site. It was double-blinded, blinding the patients as well as the investigators. Cluster randomization was done of households. We'll be coming to the details of that. It was a placebo-controlled trial with 1:1 allocation of households. They used block randomization, which was done using a computer-generated list, which was centralized, was kept in the DTTC center, which was the center which was the primary center conducting the research. And they used block randomization of varying sizes to prevent any bias and any allocation predictability. Stratification was done based on the trial site because there were 5 centers, and the enrollment period we've already discussed. Coming to the inclusion and exclusion criteria, the first inclusion criteria have been mentioned for the adults. So the adults were screened by using inclusion and exclusion criteria, and then their contacts were traced, and then specific criteria were used for these children. So the adults had to be more than 18 years of age. They had to be bacteriologically confirmed MDR-TB who had been started on treatment only within the past 6 months. They had to have a genotype or phenotype genotypically or phenotypically confirmed resistant to INH as well as rifampicin. They had to have given a consent, and they had to have at least 1 household contact who was less than 18 years who had been residing with them since the past 6 months. Exclusion would be resistance to fluoroquinolones, which was already proven in the MDR-TB, because then levoflox would be mundane as a TPT for them. So the child inclusion criteria were that the child had to be less than 18 years of age, had to be cohabitating, had to have a significant exposure, consent for HIV testing had to be obtained, consent for enrollment would be given if for a child more than 7 years, and assent would be achieved. And all children less than 5 years were included, but for children more than 5 years and less than 18 years, IGRA positive or HIV positive test had to be present. Exclusion criteria were those who already had TB at the time of enrollment, those who had had more than 14 days of INH of fluoroquinolone exposure, those who had been treated for active tuberculosis in the past 1 year, those who had concurrent exposure to being predictable to INH susceptibility, example, a mono-RIF resistant case, less than 3 kgs weight, positive pregnancy at the time of enrollment, or 6 months or less of postpartum, considering the adolescent pregnancy situation in South Africa. Although if they became pregnant during the study period, they were continued in the study. Coming to the sample size calculation, they assumed a power of 80% to detect a 60% reduction in the incidence of tuberculosis. That is, there would be 60% less chance of developing tuberculosis in the group that was receiving levoflox as TPT compared to the placebo. They have given a follow-up period of 48 weeks at which this endpoint was to be achieved, plus 6 weeks leeway period for follow-up. And they assumed a 2-sided significance of 5%. Thus, the calculated sample size was 1009. They also assumed that the cumulative tuberculosis incidence would be 7% in the placebo group by 48 weeks. They would assume a mean of 2 participants per household, and they also assumed that the house intra-class correlation coefficient would be 0.1. So because they had done cluster randomization, there would be chances that within the same household, considering similar factors, there could be similar setting and higher incidence of having tuberculosis if one had, but they did a intra-class correlation coefficient and ensured that it was less than 1. This was assumed while calculating the sample size. This would ensure that the patients were not similar to each other within that particular cluster also. And they assumed a loss of follow-up of standard rate of 10%. So the primary endpoint, which is the incident tuberculosis by 48 weeks, was to be identified, was to be studied and analyzed by modified intention to treat population analysis. Now, this would include all the patients who were randomized at the point of randomization, excepting a well-defined criteria of late screening failure, which was defined as the identification of a participant's ineligibility for the trial because it had been an undiagnosed tuberculosis case at baseline. So they had missed the diagnosis of tuberculosis at baseline, which would thus form the exclusion criteria, and hence they would take it as late screening failure. And analysis was done using STATA. So just a word about intention to treat, modified intention to treat versus protocol analysis. Intention to treat analysis analyzes all the randomized patients, irrespective of whether they got the treatment, irrespective of whether they were actually completing the study period or not. It is considered the gold standard and it is preferred for superiority trials. Modified intention to treat includes all patients with some minimal criteria. Suppose they should have at least received 1 dose of the study drug and then they could be included. Per protocol analysis, it includes all the patients who only have strictly adhered to the study protocol. So if they haven't completed the study period, they've been excluded during the study period for any time, they would not be included, and they are preferred for equivalence or non-inferiority trials. So for a more complete picture, it is ideal that all the 3 should be done, or at least ITT as well as PP analysis should be done. And ITT analysis is more conservative, but it is preferred because it preserves randomization, but it can underestimate by excluding the non-compliant patients, because in a true life situation, non-compliant patients are a reality. While per protocol analysis can lower the level of evidence, but it is the effect that would be seen in an ideal situation or an optimal situation where no one is lost to follow. So ITT preserves randomization by studying participants in groups that they were assigned to. Per protocol cannot always preserve randomization. ITT has greater generalizability because it reflects the real situation of non-compliance, while this shows an idealistic result where non-compliance was not an issue. ITT is better because it maintains the sample size, and per protocol there's less generalizability, there's more loss of patients, and there is not, the factor has a true effect on the treatment is not something that can very well be established. ITT also eliminates bias, but there is per protocol may actually create bias by only including patients who followed protocol. Coming to the intervention, which was specified in the study, it was levofloxacin, which was given as OD prophylaxis for 6 months. They had mentioned scored tablets of 250 mg, which were given, but we had a doubt regarding what treatment was given for children who were small weight. So they've mentioned a 100 mg tablet also, which was given. The dose they've specified as 15 to 20 mg per kg and a maximum dose of 750 mg, while as a control they gave match placebo, which was made up of microcrystalline cellulose, which were also scored matching tablets and given as a same regimen. So they saw the children at pre-specified time periods as have been detailed after randomization, and in addition to these, additional visits were also allowed as per clinical condition of the patient. Children were evaluated for any adverse events which were related to the levoflox or placebo, and testing during study which was done was the baseline chest X-ray PA lateral. If it was suggestive, then induced sputum or gastric lavage was taken for microbiological testing, as well as for all children aged 5 to 17 years, IGRA and HIV were given. Chest X-ray was done at baseline, 12 weeks and 48 weeks, and adherence, adverse effect study, as well as anthropometry were done at each visit. Coming to the outcome measures, they mentioned, as we already discussed, the primary endpoint of incident tuberculosis, microbiological confirmed or clinically diagnosed, which included death from tuberculosis by 48 plus 6 weeks, that is 54 weeks from randomization. Secondary endpoints, primary safety endpoint of more than grade 3 or higher adverse events, which would be at least probably related to the trial regimen. Incident tuberculosis by 72 weeks, death from any cause, any grade 3 or higher adverse events which may not be related, but up to 30 days of treatment, any serious adverse event more than 30 days, discontinuation of the regimen because of adverse event, adherence, as well as a selected list of predefined adverse events. So in statistical analysis, they use the Kaplan-Meier method, which was used to assess the incidence of the event, that is the incident tuberculosis, from the time of randomization. And the Cox regression method was used to further study these Kaplan-Meier survival curves, and it was used to estimate the hazards ratio of the incident tuberculosis in children who were in the Leoflox group compared to the placebo group. Intra-house correlation was accounted for by using cluster robust variance estimator. So covariates, which are factors which can actually affect the hazard ratio, which were considered were trial site as well as age group, and they were kind of tried to remove these confounding factors by using inverse probability treatment weighting method, because they had a very small number of primary endpoints. Also, when the assumption of Cox analysis, regression analysis, that there would be non-proportional hazards, was testing using the Gromsch-Thurneau test based on Schoenfeld residuals. Just a word about what this all complicated jargon was, just an attempt to try to simplify. So a Kaplan-Meier curve, we all know, has survival on the y-axis and time on the x-axis. And we see that there are two groups which can be compared by seeing the two curves together. And each of the step downs or a step up in a inverse curve would show an event. And sometimes we see these lines which are present. These are censored events where we don't really know the outcome which has been done. And this curve can be analyzed by either using a log rank test or a Cox regression test. So a log rank test compares the survival of two groups. Suppose as a trial, we see that two groups drugs are being compared with time, while we are not trying to see the effect of other factors which are called covariates that cannot be analyzed. It is only the drug and the period of time and survival. While a Cox regression, we see that two drugs are compared for their survival on time, but we also can study the effect of other factors on this survival, which could also contribute. So these factors are called covariates, which can actually influence the hazard function. When we just see the shape or the morphology of the Kaplan-Meier survival curve, we can somehow get an idea of the survival which can happen. So when we see a more steeper curve with a shorter and a steeper drop down with more number of events, there's a likelihood of less survival. When we see a more smooth, more horizontal curve with less number of events, the likelihood of survival is in that group would be higher. So coming to the coefficients in a Cox regression, which is related to hazard, a positive coefficient indicates a worse prognosis, while a negative coefficient indicates a predictive effect of the variable. And hazard ratio, which is the exponential form of the coefficient, that is the relative change in the hazard of an event for per unit change of the covariate. So we consider the hazard rate, suppose there's a probability of death that we're talking about, is 0.39, for example, for a child, for a patient, when we see that the patient is exercising or not, smoking or not, a gender or not. For any one of these variables, if the hazard rate is 0.39, then the chances of survival are 61%. So all these are covariates that are factors which can actually affect the hazard rate. So hazards ratio more than 1 indicates an increased hazard. Less than 1, a decreased hazard, that is a protective effect, and equal to 1 shows no change. So this is a more intuitive, more direct interpretation of the hazard, which will show per unit change to change in covariate. So Cox regression is also basically based on certain assumptions which need to be met before the analysis is applied when we are planning the study, or we need to be retrospectively checked that they have been met. Otherwise, it leads to bias. So this is the list of the hazards. The list of the assumptions on which it is based. The most important of these is proportional hazards assumption. That is, the effect of a variable on the survival remains the same over time. That the same exposure would not have a cumulative effect over time. And one of the ways to check this is by using the Gromsch-Thurneau test, which has been used in our study that we are reviewing. So this is just done by a function in R or Stata, which can be done on the entire database after the analysis is done. And failing to account for the covariates time varying effect can lead to inefficient estimates or can lead to bias. So this needs to be checked. So coming to cluster randomization, which is done on households, one needs to ensure that there is no this is done when there is cluster randomization, when we're taking clusters instead of individuals. This can lead to confounding at the individual level, and this can be checked by ensuring that the intra-class correlation coefficient is less than 1. So in this study, assumption of 0.1 has been made, and one of the tests to check this is a cluster robust variance estimator, which is also as a simple function in R or Stata. So this one way to prevent this cluster confounding is that if you have a higher number of clusters, compared to the elements within the cluster. So less will be the chance of having its design effect on the study. This has to be taken care of while calculating the sample size as has been done. So coming to the inverse probability of treatment weighting, this is a statistical method to adjust for confounding, more commonly used in observation studies, can also be used in trials. So basically it can only, unlike randomization, account for measured confounders, not unmeasured ones. And here it statistically creates a pseudo population where all covariates are assumed to be similarly distributed between two treatment groups, and it allows researchers to examine the effect of each of these on groups that are otherwise similar with this assumption. So in our study, what they have explained is that they used a two-step model. First, they used the logistic regression to predict the probability of being randomized to either group, levoflox or placebo. And after this, they gave heed to site and age group, which could be two other covariates. And they used a Cox model to further check if this was even distributed. So in sum, this whole exercise was done to just make sure that the two groups were equally weighted by site as well as by age group. So they just tried to balance these confounders. Coming back to our consort statement, the trial design has been well explained. The methods of concealment, important changes, none were made. Participants, interventions, outcomes we discussed are well described. However, changes were not applicable because they didn't change anything during the design. Sample size was determined, yes, and interim analysis was done. They had an interim data safety monitoring board which checked for the safety 4 times during the study period. Randomization, sequence generation, properly explained. Allocation, concealment, how they did, they've given a detail. Implementation also they've given, because it was only a central statistician that had that list and not all the sites. Blinding, they have mentioned that it has been done as a double-blinded trial. Although in the study article as well as in the appendix, there is no mention of how exactly the blinding was executed other than the matching tablets. So this can be something that needs to be considered. And similarity of interventions were just that the tablets were similar and nothing else has been specified. Statistical methods have been explained, and any subgroup analysis they've done, and they have explained that it has been done using age, using HIV exposure as well as IGRA positivity. So they've also mentioned that they will be calculating a number needed to treat by 54 weeks. Coming to the results of the study, this is just a flow chart of participants through the study. So the first we saw that they screened adults who were MDR-TB, microbiologically proven. From them, of 5,000 adults, they were able to screen out, for as per their needs, 631. And these were meeting the inclusion criteria. From these, they screened 1,000 to 120 children. After using the inclusion and exclusion criteria, they were able to find 922 participants, so which is less than the calculated sample size of 1009. From 497 households, they were enrolled and assigned to the trial regimen. So these were randomized further. So there were 2-step enrollments, one of the adults and one of the children. So from there was an allocation into 2 groups. 453 children were allocated to the intervention group, levoflox group, and 469 to the placebo group after using the inclusion-exclusion criteria. Further, they had late screening failure that we defined before, which were tuberculosis, which were missed at baseline. And these, the above numbers were used for ITT, while these were used for a modified ITT for primary endpoint. And these were almost similar in number. So for modified ITT, we had a sample size of 451 and 465 respectively. Further exclusion were for per protocol analysis, and these were done on follow-up. And finally, the analysis pass were done for per population using sample size of 378 and 407 respectively for levoflox as well as the placebo group. So we saw in the flowchart that all of them have been accounted for in number. Coming to the description of the baseline characteristics of both the groups, we see that they are very closely matched in all parameters, including general demographic features as well as IGRA status. Another finding was that there was a very low incidence of IGRA positivity, unlike what they had predicted in the study. HIV status, BCG vaccination, their different sites. The most important center for recruitment, about 50% patients came from the Desmond Center. And also we saw that these were very comparatively well-nourished children with a median weight for age score of about 0.4, which is rarely seen in countries like ours where malnutrition is a rampant problem. So in the consort statement, we see that participant flow has been well given. The losses, exclusions after randomization with reason have been well specified. Recruitment dates as well as follow-up periods have been well specified. Early trial ending was not done. And a baseline table showing both characteristics has been well given. This is also another table in which they specified the reason for why the, in addition to the definition rate screening failure, other patients were excluded because of various reasons. So these have all been specified in this study. Coming to the results of the primary endpoint, that is the modified intention to treat analysis for seeing the incident tuberculosis in the liver flocks as well as placebo group, we saw that 5 of the patients in the liver flocks group developed tuberculosis during the 48 plus 6 week period, of which 4 were microbiologically confirmed and 1 was unconfirmed. This was 1.1%, while in the placebo group there were 12 patients, forming 2.6%. Now this is much lower than the assumption of 7% that they had assumed while calculating the sample size. This is a significant difference. This was seen to have an hazard ratio of 0.44. That is around 56% less chances of a child developing tuberculosis in the liver flocks group compared to the placebo group. And the p-value, however, is 0.121, which is not statistically significant. They've also mentioned an absolute difference in cumulative frequency incidence. That is the cumulative frequency incidence of liver flocks compared to a placebo group of minus 1.3. So when the reciprocal of this, that is the number needed to treat, came out to be 58.8, so rounded off to around 60. That is to prevent one MDR patient case being developed, they would have to give liver flocks to around 60 patients. That was the number needed to treat, which was calculated, which is quite high actually. As we saw in the baseline characteristics, more than around 90% of the patients were actually belonging to the age group of less than 5 years. So they also did a subgroup analysis of all patients who were less than 5 years. In that, using the modified intention to treat analysis, they didn't give a p-value because it was not powered for this. However, the hazards ratio was 0.45, which was still not statistically significant because we see that the confidence interval is crossing the midline, that is 1. Coming to the forest plot, which is given in the study, we see that for all the parameters, be it the primary endpoint or secondary endpoint related to incident tuberculosis at 72 weeks, or pre-specified sensitivity analysis, that is the subgroup for less than 5 years, or per protocol analysis, or site-based incident tuberculosis being adjusted for these covariates, we see that none of them is showing a statistical significance. They're all crossing the midline, and they are all having a confidence interval which includes around 1. So although the incidence of tuberculosis in the liver flocks group is less, but it is not statistically significant. Here, another good point in the study is that they've mentioned that for confidence intervals of secondary endpoints, they have not adjusted for multiplicity, that multiple covariates could affect this, and hence they should not infer definitive treatment effects. Although these are not significant, but if any of them was found to be insignificant, we should have interpreted this with a pinch of salt, considering that they have not adjusted for multiplicity. Coming to the Kaplan-Meier curve, we see that these are two curves, the blue being the placebo and the yellow being the liver flocks. The shaded areas represent the confidence interval, and we see that each event is showing a step up. So we see that the number at risk to begin with in the placebo group was 465, the liver flocks group was 451, of which with time, as the incident tuberculosis cases develop, the number at risk decreased, but the number of cases in the placebo group were found to be 12, that is 2.6%, and liver flocks group were found to be 5, that is 1.1%. And we see the hazards ratio, as we discussed, was 0.44 with confidence interval which is crossing 1 and a p-value which is not significant. Coming to the safety endpoints, they also assessed all of them, giving p-values which were less than, which were more than 0.01, 0.05, sorry, and they were not found to be statistically significant. So they did establish that levoflox was a relatively safe drug. They did have one case which developed significant tenosynovitis, for which the child was excluded from the study, and that was the single case which had a termination of the drug being given, which is directly correlated to levofloxacin. So it was established that it was a relatively safe treatment to be given, even though it is not an FDA-approved drug. So in conclusion, which was mentioned in the trial, in this trial involving children with household exposure to an adult with MDR tuberculosis, tuberculosis occurred in a smaller percentage, that is 1.1% in levoflox group compared to the placebo group, that is 2.6%. However, this difference was not statistically significant. As they mentioned that they need to probably do more trials and combine the information from other trials to have a better interpretation of these results. So coming to the consort statement, they've clearly mentioned the number analyzed, and they've clearly given the denominators for each and what group progressed how. Outcomes have been clearly mentioned. They've given confidence interval. For binary outcomes, they've given absolute and relative cumulative frequencies. Subgroup analysis have also been mentioned, and side effects have been clearly studied, and a statistical significance has been tried to be found. Coming to the limitations that the study themselves have reported, the incidence of tuberculosis in the placebo group was found to be lower than anticipated. That is 2.6% versus the 7% that they had assumed at sample size calculation. This could mean a significant underpowering of the study. Findings of the trial have limited generalizability because in this population, more than 90% of children were younger than 5 years. Although this is the population which needs to be hit hard with the TPT because they are at highest risk, but they can't say that those adolescents who have more non-household exposures, you can have a similar generalizability, which is a needed analysis when you're trying to understand what population needs to be started on the drug and where finances have to be invested. So also in the trial, they could not determine of those patients who developed incident tuberculosis of the MDR strain. They didn't do a genomic or phenotypic study correlating either with the index patient or with the other household trials. And this would be important because primarily in South Africa, 13% of patients have fluoroquinolone resistance. So other limitations that we noted in the study were that sample size was calculated for a power of 80%, which was not met. That is 922 was a sample size compared to 1009, which they tried to meet. Also because the incidence was found to be lower in the placebo group than they had estimated. The actual sample size which would be needed would not even be this. It was coming out to be around 1490 when we tried calculating. So this would mean that this study was not powered well. Also, the proportion of Black patients in the randomization groups were 81%, which is quite significantly different from our country, where an application can be thought of be deterred by this. And MDR is known to disproportionately affect Black Americans in the South African population. So it did not show much heterogeneity. Also, malnourished children were not very rampantly included. They had only less than 2% patients who were having a Z score of weight by height less than -3 standard deviation. The median standard deviation was 0.53 with a range of -1.2 to 0.3. So these malnourished children form actually a major chunk of our contacts in LMICs. And the recent trials have shown that even simple nutritional interventions can have a protective effect. So that is not very applicable to our population if they are not included. The incident tuberculosis was not microbiologically confirmed. They've given a loose definition of either microbiologically confirmed TB case, death by TB, or a clinically confirmed. So they've not given any cutoff for any radiology or any fever symptom or cough duration, nothing. So there could be a lot of bias or subjectivity in trying to see which case was taken as an incident TB. Cases could have been missed, cases could have been overestimated. So there's no mention of how follow-up was ensured during COVID lockdowns, because we can see that they have clearly mentioned that there were 2 gaps in their recruitment period. So we know that no new cases were recruited during the lockdown as well as during the funding program. But how are the recruited cases actually followed up? No mention in the protocol or in the article. And Livoflox, at the end of the day, is not an FDA-approved drug for children. So one needs to measure the benefits and the risks. So study strengths. It is a multi-centric study with an adequate sample size. Randomizations was stratified by site and it was adjusted for aid by using different statistical methods. Independent Data Monitoring Committee, that is the DSMB board, was actually used to review unblinded interim data at least 4 times during the trial, ensuring high grade of safety of the patients. And this was mainly done when around 500 children had been followed up for at least 24 weeks, that is mid-period. And for intra-house correlation, because of cluster randomization, they used cluster robust variance estimator to overcome it. And in the consort, they have mentioned limitations which additional have been found. Generalizability depends on the country or the site that is being interpreting. For our setting, maybe not so much. And interpretation, they've also given that more studies are needed, and they've also accounted for the harms that could have been seen in. Trial details have been clearly mentioned, as well as a full protocol is available online. Ma'am, shall we proceed to the CASP checklist?
I think you have done a detailed work. You just sum it up now, and because we're running out of time. And
yes, so the checklist would just have a few of the repetitions. We will be seeing that PICO was met very well. Randomization has been properly mentioned, and they've also mentioned the computer-generated checklist. Participants were accounted for at the conclusion, yes, because all sorts of analysis was done. Study was not stopped early. methodology was sound, blinding was mentioned, but they have just not mentioned exactly how the blinding was executed. Differences between the groups were not present because baseline characteristics were similar. Apart from the experimental study, they've mentioned a clear-cut follow-up period. They have given a clear-cut intervention that was done at different time periods and protocol. So they've given a clear flowchart of the dots representing compulsory visits and the dashes representing as needed visits for all of these patients for different tests. This is a clear predefined protocol. Results, power calculation undertaken, primary, secondary outcomes measured. They have predefined follow-up plans. Dropout rates, which was not covered in the consort, was that they were similar because there was a 10% dropout in the Livflox group and 12% in placebo group. This could not have caused a difference. P-value was properly reported. Sources of bias were identified as well as addressed using statistical methods. Confidence interval was mentioned, hence the precision was addressed. Benefits to our population is an important point here. We can't really tell the cost effectiveness because the cost effective analysis has not been undertaken by them, although the harms they try to study by detailing the side effects. Results help locally. Well, they should in theory, but the problem is that can this be applicable to our population? Similar population in our country, not so much. Why? Because there is racial difference. There is underdiagnosis of MDR-TB in our country. There is still a lot of overcrowding, socioeconomic issues, and we need to be doing testing more frequently compared to South Africa. Malnutrition is a rampant problem, which is not something which is so frequently encountered there. Outcomes important to our population, yes. We are standing at the door of 2025 when we plan to end 2025 TB. And that is nowhere near in sight, but more needs to be done. Hence, TPT could be a very strong pillar. Some things that probably if a study like this is done in India, additional information that we would want would be maybe including a higher adolescent population, but primarily powering the study to 0 to 5 population, because that is the first target of our NTP strategy, where we want TPT to work well. We would probably take into account overcrowding and clustering would be different and more complicated in our setting. And socioeconomic backgrounds would also be something that we need to account for. Primary fluoroquinolone resistance is not as well studied in our population. Screening of other family members would also be something we need to know. We know that all households have more than one adults which have a TB. And we would also want information regarding duration of ATT taken by the index patient before prophylaxis started. They've just said within the last 6 months, but infectivity, as we know, with treatment can go down. So that needs to be accounted for. And limitation that would be applicable would be that their population is predominantly of a Black race, of a well-nourished population, and this is an underpowered study which would further need adult studies. Can this be useful as an intervention? Yes, because in India, Livflox is available over the counter, and hence it would be a good intervention, and not much skill would be needed, as it can be just given through the existing DOTS regimen dispensing system. And possible of us reinvesting resources into levofloxacin, yes, it can be considered, and it is being considered in the current NTP program. So just a word about another trial which has been recently published by Greg Fox in NEJM again, where this was used for all age patients to see if in Vietnam the TPT using Livflox would be useful. So here they included all ages, but majority of patients were actually adults, and their objective was to define the efficacy of Livflox in preventing development of bacteriologically confirmed TB. So here there was a better defined criteria of knowing what it was being looked for. The results showed that Livflox was associated with 45% reduction in microbiologically confirmed TB incidence at 30-month follow-up. So they had a incident rate ratio of 0.55 with a confidence interval again crossing 1. So p-value was not statistically significant, although the reduction rate was quite significant. Incidence of grade 3 to grade 4 adverse effects was low, and it was seen to be a little not very different in different age groups, although the lower incidence was found in children. Using these two studies, a recent meta.
I think Khushbu, now I think you could leave it.
Yes.
Because let us discuss the paper.
Yes, ma'am.
Whatever question there are.
Yeah. I would now thank you, Kushbu. That was a really detailed analysis, and I think you have covered most of the ways that one could analyze, and you've also talked about the statistics that the statistical tools that are used. You've used the protocols very well. I invite Dr. Matthews to comment on Kushbu's presentation, and if there are any questions to be asked.
No, thank you, madam. I think she has done a thorough kind of summary of whatever was in the paper. So we should open this now for comments and questions from the house.
I had asked for questions in the house, and I had asked them to put it in the chat box. I really
Yeah,
don't.
there was one in the chat box which I have replied already.
Yeah,
It was about how the sample size was calculated.
Yeah. Kushbu, how do you grade the adverse effects? They said grade 3 and the adverse effects. Was there any mentioned about how they were grading the adverse effects?
Yes, ma'am. They've used the standard grading, which has been defined by WHO also, and they have a clear table which is defined more than grade 3 or grade 4, which has been taken as significant, and 2 to 3 and less than 2. That is the 3 categorization they've used as a modification to the WHO standard categorization.
I do understand that the results were not statistically significant when you gave levofloxacin versus you gave a placebo, right? But would it be ethically right to even deprive a single patient who could develop an MDR-TB, if not on a program basis, but at a personal level? If a patient is being seen at a clinic level, what would your comments be on that?
Ma'am, already for even mono resistance to INH, levoflox is being advocated as prophylaxis as well as in the regimen for treatment. It is a cheap drug. It can be included in the program very easily, as we just talked about, as well as the number needed to treat is 60. For a population of 7 billion people, every 60 being given and 1 being prevented is a good bargain. So just that the evidence, probably there needs to be more studies, and country like ours need to be represented, because for MDR-TB, South Africa, because of all the trials they're doing, has made rampant decrease in their incidence as well as their children being healthier now in their nutrition also. While we are lagging behind and we have such a rampantly increasing population of tuberculosis. So studies like this actually need to be performed in our center so that we can represent our population and then extrapolate in a more informed manner.
Thank you. Dr. Matthews?
No, the question is about the adverse events which you asked. So they have used NIH grading, wherein grades 3, 4, and 5 are regarded as severe or serious. Grades 1, 2 are regarded as mild. So in this study, surprisingly, the placebo participants had more severe grade 3 and above effects, although the discontinuation of therapy was also more among the levofloxacin group. So there is little disconnect between what the investigators observed and what the patients were reporting. But that can happen in a trial of this size, so it's nothing to worry about.
And the site reported as well as the ERC reported for adverse effects as well as the incident of tuberculosis, there's also some discrepancy there, sir.
Yeah, Dr. Goel has asked a good question, that children below 5 years were all given tablets. So it's very interesting in this study that the dose for adults was 15 mg per kg, but the dose for children was 15 to 20. And everybody has been given a 250 milligram tablet. So a 250 milligram tablet can be broken into just 2 halves of 125 each. So practically speaking, some children would have ended up more on the 20 mg per kg side. Some would have got closer towards 15 mg per kg side. So they have not actually calculated the median or mean dose per kg body weight in both the groups. It may not make much of a difference because at least 15 mg everybody would have got, but this is a minor point which is worth looking into.
Sir,
and
in
no
the
syrup was
protocol,
used. Everybody's used tablets.
in the protocol, they've mentioned 100 mg tablets were also procured from the same company, Macleoid India itself, which also was scored tablets. So they've mentioned a dose per dose regimen as well as a range in the initial protocol of the study. That 100 mg tablet was divided into half. So for any between 3 to 9 kgs, they've given half of that tablet, which would account for the 15 mg per kg. So
but in the
they haven't.
paper, they only talked of 250.
Yeah, what we discussed earlier also with Kushbu was that, for small children less than 5 years to swallow a tablet is very difficult. And when that is why in the TB program we have these dispeps tablets which dissolve, self-dissolving tablets. So, and syrups, of course, are not recommended. So how actually it has been given to these children is something which raises a question.
They've mentioned dispersible scored tablets only, ma'am, but yes, for smaller children, it could be a challenge.
Yes, code also is a tablet. Code tablet means it can be halved. And once it is halved, even then it stays a tablet. No, small kids don't swallow tablets. I think that's the problem.
They were dispersible, ma'am.
They were not dispersible.
They were, ma'am. It's mentioned in the protocol, not in the article.
Right. Some things are given in the protocol which are now
Okay.
missing in the main paper. This is one of them.
Okay, then it's okay. If they were dispersed and they were dissolved and all that, then it's fine.
Yes, ma'am. They
So
have
if you were to undertake a study of this nature, what would you do differently?
Ma'am, first again, the less than 5 population that we want to hit hard, I would probably power the study for that incidence. We would see, maybe do a pilot first to see what is the incidence of tuberculosis with contacts. We have a rampant population in our adult clinic as well as in the pediatric clinic. So we can again screen adults, find out less than 5-year-old contacts and see what is the actual incidence probably. And then from that, see a power calculation, see a sample size, and then first target that group, rather than trying to expand it to the adolescent group. Malnutrition should be equally distributed and should form at least 20-30% of the patients, unlike less than 2% that they've included. Because they've seen in recent trials that even just giving nutritional supplementation and the Nikshay Poshan Yojana has all improved in the prevention. That itself is being taken as a TPT. So that would also be one confounder that we should account for. And just we need to start doing this because our population is not represented. South Africa is leading the research and India is the one that needs to see the daylight in such research.
Dr. Rawat has a question in the chat box about ethical aspect as well as
Yeah, I think we just discussed this.
okay.
We're all pro.
There's something about incident tuberculosis diagnosis. How was this made? That has been there in the protocol.
So they mentioned clinically diagnosed, for which they have not mentioned any criteria. So it could be a clinician's discretion or a microbiologically. Both were taken. And the third factor was death due to tuberculosis by 48.
Like whether they did any other investigations like chest X-ray or sputum induction or BAL or anything of that kind in symptomatic patients. That's not done.
They've mentioned that they've done a chest X-ray at at baseline at 12 weeks and 48 weeks, ma'am. But again, X-rays can be subjective. So they haven't mentioned any criteria like our guidelines do, nor fever nor cough criteria. But microbiologically, when the X-ray was suggestive of changes, they've done GA-CBNAT or GA or an induced sputum, for which they have subjected to CBNAT as well as MGIT from standardized labs. So microbiological diagnosis has been standardized. This clinical is a little undescribed.
And they didn't describe how many of them were actually MDR, these incident cases?
No, ma'am, they haven't done a microbiological strain. They've just done diagnosis. So that was one of the
But
limitations.
they
They
did MGIT, no?
It's
Yes,
a
ma'am.
big problem. They have not done that at all. So we don't know whether the children got the same type of TB.
Yeah, or they got TB from elsewhere, you know.
Strain has not been identified genotypically or phenotypically.
Okay.
They also mentioned that
Then were microbiology. Sorry.
they also mentioned that they took patients who had complied to up to 80%, like 4 weeks of defaulting treatment was acceptable to them. Would you consider that a good point, or would you beg to differ there?
Ma'am, considering real life situations, we do know default is a problem. So maybe just as a starter, they've included it, but that can itself be a problem. That could lead to fluoroquinone resistance also. And that is an issue that needs to be addressed, but maybe a lower cutoff.
Dr. Matthews, would you like to make any comment before we then, if anybody else in the house wants to?
No, Dr. Rawat asked an important question. Actually, it's not incidental TB, it is incident TB. So what they've actually done is first they've ruled out that all the children didn't have TB to start with. So that is a starting point. Otherwise, some children may already have had TB and so the levofloxacin would appear not to work. So first they've ruled them all out and they have picked up a few children who turned out to have TB, so they have been excluded after randomization. So therefore, everything else which got picked up during the trial up till the end point is either new TB, which means they have picked up TB while being on levofloxacin, or placebo. And then they have given in their discussion some justification. Okay, this could be because only 6 months of levofloxacin is not enough to prevent everybody from getting TB. So only new cases of TB. So pre-existing TB they have rolled.
Another point, sir, was that the follow-up period was much more than the treatment period. So in that next 24 weeks, we don't know if it was just again exposure or it was outside household exposure. That study period itself, why up to 72 weeks? Why not stop at 24 weeks? What is a better period?
Yeah.
Because what is the protective for those
Yeah.
24?
So the basis for that is that for drug sensitive TB, the IPT is given for 6 months only. That is one. And nobody knows the safety of long-term levofloxacin. So they've used 6 months as a justification for that. And they've correctly followed. Only problem is they tweaked the follow-up period thrice during the study. It was originally supposed to be 72 weeks and they made it something else. And finally at 48, they kind of more or less decided not to do any further. So we don't know what will happen to these people if they're actually followed up for longer periods of time. Some will develop TB, and whether the difference will narrow or not. That
Would you call it protocol violation if they had written all that in the protocol? And then
they kept
changed it.
they kept tweaking the protocol, ma'am, in between.
Yeah, okay.
And for example, originally they didn't plan to take children beyond the age of 5. That was also an afterthought, and for some reason they have included them. Although it's only 10% of the children, but they did all that.
Sure. If there are no more questions, and I would compliment Khushbu for a wonderful analysis and presentation, and I think it's been a great start to the Journal Club.
Thank you.
Dr. Bafna or Dr. Rawat, any comments?
Dr. Khushbu, you have done an excellent job. Now, what message you will give to the viewers? Because as you know, levofloxacin is a recommended drug by WHO and even by National Tuberculosis Program, and we all been using levofloxacin for TPT. And now you have shown us 2 studies where levofloxacin is not better than a placebo as a TPT drug for MDR TB. So what message you would like to give to the people who are viewing this program, that whether they should use levofloxacin or it's a useless drug?
So the major concern for pediatric population was efficacy and safety. Now, safety has been well established by both trials, that there's been no significant harms that have been done over even a period of 72 weeks. So safety-wise, we are more sure than we were before because of these studies. And earlier recommendations were based on just observation studies. Now at least we have 2 RCTs. The last slide that I could not display was a meta-analysis of these 2 studies, in which by using Bayesian analysis, they've shown a p-value of less than 0.05. So when you mix up the data of 2 trials, including all adults as well as the children, they have seen that it is protected. So obviously we need more data. So in the meantime, we need to have our own studies. Why not do the study and prove that we are doing a good job? And in the meanwhile, we can continue. So India, we have so many children who are at risk. So we need to start probably giving the drug and seeing the effect while we know that it is safer. So because of these trials, we know it is safer to give than we were in the light of that, and to continue with that and see how our children are behaving, considering our malnutrition, considering our overcrowding in socioeconomics.
But I think its availability over the counter is not something like a good factor. This is something which will promote levofloxacin resistance also. So I think we have to, go slow, and we can't say that, yes, this is the drug for, not yet. I guess one has to try it first in our setting and then see what's happening in proven cases of multi-drug resistance and their contacts.
Thank you very much.
There are 2 more questions in the chat box, sir.
Dr. Pooja Chaudhary says, is there any mention whether actively to look for levofloxacin resistance in source contact, because sensitivity to levofloxacin is not met? I think you mentioned that. For inclusion criteria, it's mentioned only in the exclusion criteria. source site resistance. The incidence of levofloxacin resistance was high among MDR cases, reported up to 40%. Nothing mentioned about the source contact, whether the source was compliant or treatment responsive, or whether source was isolated from his own family members.
So this was one of the limitations for second point, that this was not mentioned, which should have been mentioned. Point one, they have given adult inclusion criteria and exclusion criteria, in which they've mentioned levofloxacin genotypically or phenotypically fluoroquinolone resistant proven. So those were patients who were MDR as well as fluoroquinolone not.
I think the adult study will come up as a separate study, because all these MDR cases also they've followed and included. So that will be published as a separate study.
Dr. Joseph Matthews commented that population levofloxacin resistance is about 13%.
That is in South African population, which they've given in their own study.
Yeah.
And I think one point we need to emphasize is that what Dr. Kushbu has told us, that levoflox is of utility for TPT and MDR TB. So we should not use this drug indiscriminately for respiratory infections. I think this is a very important message which Dr. Kushbu has given us, that this is a drug which can be used to for TPT. So request to all the pediatricians that please don't use levofloxacin, because they are inclined to use in adolescent children to treat pneumonias and all those things. So try to preserve this drug, conserve this drug, because there are now solid evidence that this drug is safe in children. And MDR TB, as Dr. Kushbu has mentioned, it's a menace which we have to counter. And for an aim of end TB by 25, contact tracing and TPT is one of the cornerstone to prevent the TB spread. So I think we have got evidence that levofloxacin is going to be useful. So one message: please preserve levofloxacin. Don't use it indiscriminately, and use only when it is really indicated. Let us wait for more data where we can use this drug more confidently for TPT and MDR TB. Thank you very much.
Yeah. Actually, off late with the resistant mycoplasma infection that we have been seeing, many people have used levofloxacin or even over doxycycline. Maybe the first drug of choice there should be doxycycline.
Yes.
Levofloxacin.
I think adult pulmonologists are very used to using levofloxacin for any pneumonia.
Yes, because of the wide spectrum of coverage that it has, covering atypicals as well as the the resistant bugs, like resistant strep also. So I guess they use it very ruthlessly.
Yes, ma'am. Yes, adult pulmonologists are using levofloxacin very widely, ma'am.
I think in pediatricians, I've seen an upswing because of the resistant mycoplasma that we have seen last year. I guess we should restrict ourselves to using doxycycline there. Thank you very much. This has been really a wonderful start. And thank you, Kushbu. Thank you, Dr. Matthews, Dr. Rawat, Dr. Bafna, Dr. Ajay, Dr. Meenu Singh, and everybody else who took out time to join us today. We will continue this activity, and I'm sure all of us will benefit a lot with this scientific activity. Thank you so much.
Thank you. Dr. Ajay Kumar, you can just conclude it.
Thank you. Yes, sir. Dr. Khushbu, thank you for your very elaborate and very current issue that you have raised. And I also thank to Ma'am Meenu Singh, ma'am, for mentoring the Khushbu and this paper, as well as Dr. Joseph Matthews, sir, for their expert, their reply and the questions regarding this paper. As well as I also thanks Dr. Indu Khosla ma'am to beautifully conduct this coordinating these activities, and as well as Dr. Bafra sir for your kind presence, and ultimately our chairperson sir, Dr. Rawat sir, for initiating this activity and thoroughly present in this activity throughout the whole time. And thank you all of us, and we again meet in the next session on the every third Wednesday of every month. So by this, can I conclude the session, sir?
Yes. Thank you very much.
Thank
Good
you,
night
sir.
to all.
Good night. Good
Thank you.
night, sir. Good night, all. Thank you, ma'am.